or evening, depending on where you are. I'm really, really happy to be in conversation with such esteemed panelists. And I think you've seen for those of you joining us remotely, that their bios could have us here all day. So we've asked you to please just use the QR code. For those of you who are in the room in person, please use the QR code to just scan their bios. We've been trying to sort out some tech difficulties to make sure that all of us are here, and hopefully we will be able to get through. And so before we begin, I actually wanted to acknowledge Indigenous peoples past, present, and future as the rightful and traditional protectors and caretakers of their native lands in what is now known today as the United States. And I want to recognize that the University of Maryland School of Law operates on the ancestral lands of Arawakian-speaking peoples and Algonquin-speaking peoples, all of whom share this area through their relations and whose descendants are thriving despite settler occupation. I also want to acknowledge the people forcibly kidnapped and sold from Africa, who were enslaved on these lands and who worked on these lands from the colony's founding in 1634 until 1864, when the state of Maryland abolished slavery. Enslaved Africans were exploited and did work on this land, enabling us to live as we do today. And I think recognizing these and connected injustices serves as an opening to contemplate the continuing resistance to subordination through various social movements that are aimed at creating more equitable relations. And I've asked all of the panelists to reflect on how they came to global health, and so I will begin that conversation. And so my interest in global health was sparked through witnessing the devastation that the HIV and AIDS pandemic had. And I had volunteer opportunities in Kenya where I worked at an AIDS orphanage. And I also remember interning at an organization called the Global AIDS Alliance. And I remember the futility that I felt contributing to advocacy efforts aimed at convincing policymakers or trying to convince policymakers to fund initiatives like the Global Funds for AIDS, Tuberculosis, and Malaria, or the US's President's Emergency Plan for AIDS Relief, also known as PEPFAR. And when I bared witness to the 2014-2015 Ebola epidemic, which is where in West Africa, I was driven to try to undermine simplistic accounts that make it seem as if pandemics, epidemics, sort of happen due to individual actions, maybe due to local backwardness. And so health inequality, health vulnerability, health incapacity are sort of naturalized as inevitable. And then we need the munificence of international actors to sort of like solve those things. And I was struck by how both the HIV/AIDS pandemic, the Ebola epidemic, but also mpox more recently, have resuscitated images of Africa as this dark continent, as this barren wasteland. And one of the things that has happened is this sort of quotidian and routine nature that has normalized the suffering and vulnerability of those who are presumptively diseased. Black people are presumptively diseased, Indigenous peoples, and other historically subordinated groups. And so my interest in global health is aimed at sort of my interest in international law more generally, which is trying to make visible the historical and ongoing effects of colonialism, material exploitation, and structural racism. And so when we think about inequality in global health tends to think about inequality mainly along sort of income disparities. So you'll hear terms like high income countries, low income countries, and then there will be sort of confusing how those countries came to occupy those positions, right? So there's no real attempt at historicizing or contextualizing inequality. Inequality just exists and is either happenstance or routinized. And so this myth crucially ways in which inequality is structured transnationally and internationally. And so my work has been aimed at trying to identify the ways in which international law, international institutions, and international policymaking can reify and reinforce subaltern positions of Black peoples and other subaltern peoples who have historically lacked power, and nationally, regionally, internationally. And this we know through just the process of international lawmaking, right? So international law is made through states, and states dictated the terms of entry of other peoples into the terms of state, into the club of statehood. And so at the time of the World Health Organization's founding, about a third of the world's population remained subject to colonial domination and rule. And since since then, a fundamental question has been whether it can sort of make a clear break from that past. And that's been a central issue shaping its work. And following the period of decolonization, newly independent countries who had fought for their liberation sought to really reshape the world in equitable ways, including in health. The non-aligned movement of states, if you recall, which was founded in 1961, brought together countries from Asia, from Africa, from the Americas, and the Middle East to try to advance their interests. They also advocated for change in global health through the Declaration of Alma Ata. And one of the things that I think is important to think about in this panel, as we think about the field of global health towards transformation, is how the push for transformation is not sort of some new thing that is only connected to the present day, but it's linked to longstanding efforts to try to create more equitable relations within the international order, and specifically as it relates to health. And one of the things I wanted to highlight is that the World Health Organization was founded in part on the principle that the extension to all peoples of the benefits of medical, psychological, and related knowledge is essential to the fullest attainment of health. And so it's important for us to think about to what extent then has the World Health Organization and Global Health use their policies towards these redistributive ends to try to give effect to this principle. And so when I look at the foundational documents of the global health regime, I see no mention of structural discrimination in public health and medicine or global public health. I don't see any mention of reparations within the documents, the constitutive documents. This is a far cry from the new international economic order that I mentioned, which had proclaimed the right of all states, territories, and peoples under foreign occupation, colonial domination, or apartheid to restitution and full compensation for their exploitation and depletion and damages of the natural resources and other resources, which includes peoples, not just states and territories. And so when we look at the formative instruments of the global health regime, we don't see any acknowledgement of this history. And that then renders the numerous genocides against indigenous peoples, the transoceanic, transcontinental trade in enslaved Africans, the dispossession, colonialism, scientific racism, medical neocolonialism, and host of unfreedoms that subaltern peoples have experienced and continue to experience, which structure our international order as inconsequential. The constitutive instruments of the World Health Organization do not contain any provisions aimed at what's called positive measures, affirmative action measures, or special measures in international law to try to mitigate this history in global health. And so there's this silence on the need to repair, on the need to redress, on the need for redistribution. And so one of the things that does then is it backgrounds and renders sort of quotidian this immiseration that exists in our health systems, in our health infrastructure, in the health outcomes of peoples, in the quality of life and well-being of individuals around the globe. And so when we reach the current moment, there are several legal developments that are taking place that have the potential, perhaps, to reshape global health. In May, the World Health Assembly, May of 2022, the World Health Assembly formally initiated a process under the auspices of an intergovernmental working group on amendments to the 2005 International Health Regulations. All member states are required to comply with these amended regulations. Additionally, there have been efforts to try to draft an international treaty for pandemic preparedness and response to build a more robust global health architecture, which reached an impasse in 2024. The World Health Assembly has extended the negotiating deadline to conclude this agreement to May 2025 this year. And in large part, the gridlock has been because of tensions between Global South and Global North countries around trying to get more transformative provisions in the global health regime um, aimed at addressing health inequality. And so one of the lingering questions then is whether these reform efforts can address the colonial legacies within global health and point us towards more emancipatory futures. And so that is the question for us today. This panel is going to serve as the space for analyzing global health's past, thinking about global health's present, and maybe reimagining the role of global health in the world today. In lieu of formal introductions, I began with this, my own personal reflections, and I've asked the panelists to do so. And so we're going to begin in reverse alphabetical order with Claire.
Thank you. Thank you so much, Matianga, and everyone for being here and being online. It's an honor to be here. So as you said, you wanted some introductions about how did we get here? How do we get to global health? And I guess by accident is the answer. And I say I'm very conscious I'm in a law school and I'm not a law academic. I'm an international relations academic, right? And I like to sort of say I'm a vibe-based person, right? Like we don't, in IR, we don't talk about law. We talk about like what's the general vibes that are going on in global politics. And that's sort of what I'm hoping to bring to this conversation. But I got into this by accident. I left my undergrad and I got a job in a policy role in the NHS, our unified health system in the UK. And I hit a ceiling. I hit a ceiling of I wasn't a doctor, right? So you had to become, if you wanted to actually think about policy rather than simply implementing policy, you needed to either be a medical doctor or have a PhD. And I always thought I was going to go back into policy, and I didn't. I very quickly decided I wasn't going to be an actual doctor because the thought of blood, needles, that's just not my thing. But I thought I was going to go back into policy, and actually I realized that the great academic freedom that you get being an academic, being able to think for yourself rather than having to implement policy of what your government at the time is thinking. And I recognize where I'm saying this today is a real honor and privilege. And I think as academics, we don't recognize that as much as we should. But to kind of take that one step further, when I first started my PhD, it was, the mid-noughties, everyone was talking about security and, it was all the kind of health security stuff that I'm sure you're all aware of. It was post 9/11, it was SARS, it was IHR 2005. And what made me take a step back from that towards some of the things that Matianga has been talking about around equity, around vulnerability, around trying to redress some of the status quo, some of the systemic inequalities, really was a personal one, which was the Zika outbreak in 2014 to 16 in Brazil. I'm sure many of you can remember those really visceral images of babies being born with microcephaly. And I was pregnant at the time. And it really struck me as this disconnect between me, a white woman of privilege in the UK, being pregnant, and the reality of women across mainly Latin America who were in a very different position to me. And yet what global health policymakers were concerned about was me, right? The focus was about why are we, how do we stop people from Europe and people from America going on vacation and getting Zika and coming back? And I was like, you guys have missed the point entirely, right? It's not about us, right? It's not about us privileged few. It's about the inequalities experienced by those women in Northeast Brazil who don't have access to reproductive health, who don't have access to healthcare, who, for a variety of reasons may or may not have chosen to get pregnant. And we're completely missing the story. And I was frustrated in the global health landscape that even when we started to talk about gender, right, it was still about elite women, right? It was about representation of women in boards. It was about are there women on panels? And it was about, a women leading global health institutions. Important in and of itself, but, recognize our own privilege. And I still don't think we do enough of that in global health. So that's, I guess my journey to coming here.
Thanks so much.
Hi. Hi, everybody. FIFA Rahman, Matari Global Solutions. So I got into global health sort of intentionally. It's my dad's a pediatric hematologist. So conversations around the dinner table were always very scientific, very I became interested in health very, very early. But I was very laser focused around 15 years old on the justice of it all. What are people accessing? Are they accessing things differently because of who they are? So it became clear to me that I wanted to focus on law, and did my law degree, basic law degree, went into a Master of Health Law, and that's when I sort of started working with at first the Malaysian Ministry of Health and then the Malaysian AIDS Council, where I started working on a variety of different things, and that included the trade negotiations for the Trans-Pacific Partnership Agreement and intellectual property rules under that for biologic medicines. I worked on access to trans healthcare. I worked on decriminalization of drug use. I worked on sex workers' rights to HIV drugs, all of that kind of thing, which kind of propelled me into the global health space. And I worked on the global COVID response and was in calls every Thursday with Dr. Tedros, with the head of the IMF, and working on all these things, leading to my most recent role in advising Africa Group negotiators on the pandemic treaty, and of course running my own firm. And I run a consultancy firm, and the motto of our firm is Global Health Solutions with local relevance. And local relevance in particular is the most important part of that motto, because there are too many consultancy firms in global health that run things in the global north by global north white actors who haven't had much experience in the global south, where global health initiatives are being carried out. So local relevance and participatory methods and co-creation was central to me setting up this firm. And essentially, all of the things that Matiange mentioned, which is addressing the colonial underpinnings of global health, is why I entered this role. And knowing that I can do it in so many different areas, which is what I do today in pandemics, in HIV, in trans health, and whatever, is kind of how I got into global health. But thanks.
Go ahead, Regine. It's working. Yeah. Okay. Great. Thank you so much. Thank you so much, Professor Surley, for having me here. And thank you everyone for being in the room with us. I guess I also will start with the land acknowledgement. So I'm a professor at the University of Ottawa's Faculty of Law in the unceded and traditional territories of the Algonquin and Anishinaabe. Certainly not, of course, the 51st state of the United States of America. And I wanted to, I guess, start by talking a little bit about my trajectory in global health. That started really in my undergraduate studies. So I took a course with Dennis Raphael. I don't know if some of you may know of him, but he's sort of a leading authority on social determinants of health in Canada. And publishes lots of open access works as well. And so his work really set my mind alight, because as a Iranian Canadian settler in Canada, I had this this intuitive understanding of what social determinants of health, including immigration status, including your status as a first-generation immigrant, means in the daily life. I had seen my parents come to Canada with $100 in their pocket and have to really start to build their life, going on doing all sorts of jobs to be able to make it by. And so I intuitively understood that your health is a socially determined concept. But in addition to that, I had an additional layer of help in this work, which was I picked up a book, and it was by Tracy Kidder. It was called Mountains Beyond Mountains. That title in and of itself is really amazing. It's a Haitian proverb that refers to
solving problems, beyond solving problems, there's always another problem that will arise. There's always another mountain to climb. So that in and of itself was really ignited my mind. But it was the story that was told through the lens of Tracy Kidder about the establishment of Partners in Health, about the life of and works of Dr. Paul Farmer, Ophelia Dahl, and Jim Kim, and how they got to changing the perception of many in global health around how the life of a human being in another country, in a country where resources are far less available. That was what was transformative for me, and it was the language they were using to describe all this. It wasn't the language of assistance or charity. It was the language of structural violence against peoples and also in all parts of the world that are not the global north. It was the language of human rights, of the right to health. Of course, being in Canada, we kind of understand that there is a right to health care, but at the same time, the right to health in and of itself is not enshrined within our Charter of Human Rights. So that book for me was transformative, and really, I think, set me not only on a path to global health law, but not on a path to global health, but on a path to global health law. And so I pursued my master's in global health from there, and then I went to law school just to do global health law. So yeah, I'll leave it at that. And
we're so glad you're able to join us online. We are thrilled to have you here, and you can go ahead and unmute, and we can see you in the room, and folks watching remotely can see you as well.
Thank you, Professor Sirleaf, and apologies for all the troubles that I've been giving you throughout this organization process. I'm glad to see many colleagues and known faces. I ended up in the global health arena because I wanted to change the world. Obviously, was not the case, and now I'm in a situation where I'm saying, please, someone save me from the world. But I'm a physician by training. I specialize in tropical medicine, public health, and field epidemiology. And at a certain point, I was working in a hospital in northern Uganda. And when I was there, an Ebola outbreak broke out. And guess what? WHO disembarked there. And I saw that, wow, WHO can change the world. We contained the largest outbreak ever seen until that point in time. And it was done with compassion. It was, wow, we changed the world. And I was adopted in the field by Mike Ryan, and I went to Geneva. And this was 25 years ago. Then I've been moving through from headquarters to the WHO regional office for Europe. And then I was 12 years in the WHO regional office for the Americas, very close to you in DC. And I came back to Geneva in 2022. Then over these many years, I think I had all the global health preparedness and response seen in front of my eyes. I went through it as a technician down in the trenches and that's how I went through these decades. And progressively, I've seen all sorts of outbreaks, of course, here and there, and progressively since SARS 2003, I got involved with the international health regulations. First, when it was negotiated in 2004, 2005, with the purely technical review. And then as I moved across the globe, then I've been involved with virtually every single aspect of the implementation of and all the legal twists of the IHR. Then when I came back to Geneva, I was tasked as a technical lead for WHO of the IHR amendments, for the working group on the IHR amendment. And what have I learned in global health since then? I had to learn the hard way what being an international civil servant means, what serving member states means. And I've learned that there are no magic bullets that change public health, that it is a process, that is something physiological. And over the years, as WHO and others, we have come up with all these acronyms and toys, and let's do this. No, it's something that my dream would be really seeing being able to accompany member states whom I'm serving through this physiological evolution and institutionalization. And what I wouldn't like to see, and I'm still struggling with it, but I guess is the life with global public health, are this departure from very straightforward public health interventions, public health actions on the basis of political ground, for political motivation. And this is something that I'm still struggle with, but is what in reality is shaping global public health. And yes, what I've learned, I had no clue about the legal aspect. I had no legal training whatsoever, but over the years, I learned how to play with the legal text and how to make that legal text really serving public health. And this is really what I think is the major aspect in terms of what I understand and what I can contribute in terms of global health. Thank you, and over to you.
Oh my goodness. So we are really, really privileged to have with us today some, I already said we had a formidable lineup, and now you've heard that we actually have a formidable and brilliant lineup with so many diverse experiences. We have practitioners, we have academics, we have doctors, we have lawyers, we have IR people, we have folks who are getting their hands dirty doing the work in global public health, and then we have folks who are doing some more thinking about what can be happening in the field. And so I'm really eager, and I'm sure you are, to sort of jump into our discussion today. And so I want to turn our attention to some of the reform efforts I mentioned in my introductory remarks, beginning with the pandemic treaty. And I want us to structure this round around thinking about the potentials that it presents and the challenges. And so to start us off, we'll begin again with Claire. And Claire, for you, I just want to have you reflect a little bit on to what extent you think progressive global health development law is possible, given your own training in NRR and our current geopolitical moment.
Great. I mean, big question. So I think, international law is predicated on a certain number of normative assumptions, right? That there's a rule-based system, multilateralism works, liberal international order continues. And, international laws, international relations theorists have always kind of discussed, is this possible, right? And what are the ends of this, right? When does it not be possible any longer? And, liberal institutionalists, people like John Eikenberry and IR would say, it's fine and it works, liberal institutionalism works until such point as we have a kind of return of great power politics, is how he terms it, right? Which is exactly what you might be arguing we're seeing now, right? We're seeing a fundamental shift in the geopolitical landscape, right? And so the question then IR would ask is, well, then what happens next? And I still don't think we know. There's a lot of potential options here. One might be that the kind of the argument someone like Polanyi would make would be that it's about rebuilding and rethinking and extending the liberal international order. So basically more international law, right? Trying to get more normative agreements and cooperation is the way out of this problem. And then you have people like E.H. Carr, who's another IR theorist, who would say, you know what, it's not going to happen. It's a return to anarchy, right? And I still think we are on that precipice of not knowing which one of those things might happen. And I think if we look at something like the WHO, the pandemic treaty negotiations, you can observe these sort of tensions and these trends maybe playing out. Because, we need a multilateral system only works if people believe in it, right? And they think and states think it's serving them. And I think we're at a point now where we're seeing that, well, I think everyone in the room can recognize this. You know, the UN system was built at a very different time, right? And it was built to serve the interests of the few, right? It was structured in a way purposefully. I mean, just look at the UN Security Council, right? Like, it's not about equality, even though it is one state, one vote. But yet those high income countries don't think it's serving them anymore, right? We're seeing like the obvious example being the US leaving, but a number of countries, a number of high income countries are not necessarily thinking they're getting what they want out of the WHO at the moment. And yet the low and middle income countries are also feeling like they're not getting what they want out of the WHO at the moment. So we're in this kind of stalemate. Well, if it's not working for anyone, do we still persevere with it, right? Or do we need to fundamentally rethink the multilateral order, rethink international law, rethink whether any of these things can happen, which is why these conversations are so important. And, you know, I think one of the key trends we might be seeing here is actually states moving away from this multilateral order. I mean, we just have to look at the rise of regional actors, right? In the case of global health, the rise of Africa CDC, the rise of the EU as actors, and actually states seeing more relevance, or rather being able to get better outcomes for themselves, so that for their electorates at the regional level and the global level. And, you know, personally, I think this is really sad. But I think we can't ignore it, right? And we can't just pretend, oh, yes, everything's working fine, let's just go as we are. And then you've got to think about the other types of states we have, right? What about the kind of middle income? What about these BRIC governments that we hear about, right? What are they doing? Well, you know, they're focused on things like the G20. They're focused on the financing for global health, right? Are they committed to multilateralism in the same way? Are they committed to the UN system and the pandemic treaty? Not so much as they are making sure the money's coming, right? So is that, you know, also thinking about the political economy, where the money's coming from. There are so many trends going on at the moment that we really need to understand better before we even get to being able to have transformative international law for global health. But it's an opportunity, right? Everything is changing and everything is up for grabs.
Thank you so much for that. And so this is, I think, a note to us to stop turning the mics on and off. We got a comment in the, I mean, we could just cut the mics, our mics off. The mics in the room, I think, are sufficient. We have a commenter mentioned that there's too much feedback. And this is also an invitation to add more questions and comments in the chat. We love to hear from you about mics and, you know, other things as well. So let's move on. Let's move on in this discussion. Regina, I wanted to turn to you. Early in the negotiations for a pandemic treaty, you worked with a civil society network that was doing some advocacy work around trying to promote human rights within the pandemic treaty. And so can you talk a little bit more about why you thought that was useful and whether member states are sort of receptive to that?
Yeah, absolutely. Thanks, Professor Surley. So the pandemic treaty negotiations are really at this moment, and I know our colleague Dr. Rahman will speak to it a lot more, but they're now towards the tail end of the negotiation process. And early on, there was an opportunity to insert human rights language within the pandemic treaty text, because it was still very much a text that was in flux. The zero draft, I believe, had an Article 14 around public health emergencies and human rights, so guiding the public health emergency response through human rights concepts like proportionality and accountability and transparency and so on. The challenge with right now, what we're seeing is that the states have really kind of latched onto concepts of equity and solidarity at the expense, in my view, of human rights language. And the problem with that is that we have over 50 years of international human rights law developments that capture concepts that we want to see within the pandemic treaty, including equitable access to medical countermeasures, including responses to public health emergencies that are human rights centered, that do not infringe, for instance, on our civil liberties unnecessarily and without a scientific basis. We have, of course, as well, which unfortunately the United States is not a part of, but the International Covenant on Economic, Social, and Cultural Rights, the big one, which contains the right to health, which contains the right to science, which contains social security, and all these other matters that are crucial to preparing for public health emergencies. the public health and human rights have a lot to say to each other. And I think we understand this at the local level, but unfortunately at the global level, that opportunity has been lost. And so I think, and I would invite my colleague, Dr. Rahman, to comment if they have thoughts, but it's a sort of a symptom of a world that has lost faith in the international human rights system, broadly speaking, as well as multilateralism, and is trying to invent, or not invent, but to see new concepts emerging that might better capture what we mean. But unfortunately, these concepts are new. So what does equity mean within the international law sphere? I don't think anybody really knows. We have definitions now, but they're still slippery. Equity is a goal and an outcome, as it's framed in the pandemic treaty process and the text as we speak. Solidarity, same thing. It's an intuitive concept. We understand it intuitively, but when push comes to shove, what does that mean, right? So I think I'm going to stop it there, but that's something that that unfortunately was a lost opportunity within the negotiation text.
Thanks for those provocations. And so, Dr. Rahman, I'm going to put some respect on you all's name. Thank you for that reminder, Professor Habibi. So Dr. Rahman, turning to you now, I wanted to hear some reflections from you, so the US is no longer a negotiating partner in the pandemic accord. How do you think that changes the prospective outcomes relating to access and benefit sharing of pathogens, and sort of, how does that practically impact this?
So thanks for that question. So when we were speaking with negotiators from the United States in April of last year, the United States actually wasn't the most difficult global north country to talk to about access and benefit sharing, simply because they were from the Biden administration. They wanted to get the pandemic treaty through before the elections. So there many conversations with the United States occurred in the way that was, okay, this is the Africa group position. How can you come closer to us? And then it was very much, we can come closer to you on X, Y, Z, but you know, our higher ups are saying we can't budge on this. But it was a lot more reasonable than some other global north countries. That said, now that there's a global north actor that was removed, and remember that global north countries are desperate for genetic sequence data from Africa and Asia. And actually, an anecdote is my dad is the head of the biobank in Malaysia, and he had a conversation with the Brits about, and the Brits openly asked him, we'd like your genetic sequence data, and he said, absolutely not. You can have tech transfer, you can't have the data. And I wanted to high five him during the Zoom call, but it didn't happen. You know, the situation with access and benefit sharing now is that the text has seen more yellowed text, which shows that there's more agreement. And when we were discussing in April last year, there was high opposition by global north countries to traceability, that you don't want identifiers to link this particular pathogen that you upload. So say you upload this from Botswana, and this particular pathogen or genetic sequence data is used to create a product that is later required to respond to a pandemic, then the countries that need it should be able to access that product, right? So you need identifiers for this. You need a digital tag in the system to know it. Otherwise, how are you going to know that this particular pathogen resulted in that particular product? You don't know. So there were lots of people really heavily opposed to identifiers. And even getting the notion of traceability or identifiers into the text was an absolute, you know, people were absolutely no. Global north countries were like, absolutely not. Now we see that there is text in there acknowledging that the ABS system should discuss. No, it's not the word. The word isn't discuss. It's it should address traceability. So the US exit has made it easier to come to a yellowing of the text on this. But there are the implications which must be considered exiting, and that the US is often the host of a lot of these platforms that have the pathogens on them and the genetic sequence data. And given the situation of Doge and you know, everything that they're doing with data, there is an issue about data integrity and where you hold that without it being compromised by sinister actors that might not have the best intentions with that data. And in developing, and obviously now we're at the stage where most of the detail will be developed later in a protocol on ABS, is that they need to think about when they develop this pathogen database, where is it going to be hosted? Because the United States is no longer a viable candidate for the hosting of that. And I wanted to say something about, I wanted to come to the human rights bit, but before that, on the databases and where does this go vis-a-vis multilateralism. In my role advising African negotiators, I had many meetings, not just with the Global North, but also with other Global South countries, such as Indonesia and Malaysia, who have domestic ABS laws. And at the end of the day, the conversations were so fraught on ABS that we don't want identifiers. It will be too complex for African scientists. You know, all these crazy colonial nonsense. It became quite clear that some of the other countries like Malaysia and Indonesia said, well, we don't, you know, at the end of this ABS, if this ABS system doesn't work, we are going to rely on our own domestic laws. So, you know, my advice to African countries was that like legal preparedness needs to go in that direction. You need domestic ABS laws. You need to start signing these bilateral biosecurity agreements with the EU and the US that is giving over your genetic sequence data without the guarantee of benefits. And you know, domestically, you need legal preparedness as well. And of course, I advise the negotiators on the human rights aspect as well. So moving on away from ABS and briefly commenting on the human rights aspect, was that there were countries that immediately interpreted human rights as solely focused on LGBTQ people. And of course, as someone who works on trans healthcare, these are things I care about. But they were very much receiving orders from capital going, you know, if we add human rights language in, it's going to be focused on trans people and LGBTQ people. And I had to explain kind of really basically that, well, the right to health applies to you as well. And also you want a trans nurse or trans doctor to receive the same remuneration as a cis doctor. But I do think even the international lawyers and the health attaches in Geneva needed a little bit of explaining on the right to health and human rights in general. So that made it tougher to come to a good point on the human rights aspects.
Thank you so much for that. Dr. Andreghetti, we want to turn to you. So you have a wealth of experience working with the World Health Organization. What have you found to be the biggest obstacle that you witnessed during negotiations for this treaty?
Yeah, thank you. I think I'm going to repeat to one extent or the other of what the other panelists already said. Overall, I think that the major obstacle, the first obstacle to overcome and a persistent obstacle was this clash of expectations by all the parties involved in negotiating the WHO pandemic agreement, because, for instance, from the WHO Secretariat perspective, the expectation was this is going to be a slam dunk, and but right off the bat, the atmosphere, the mood, the dynamics of the negotiations in the room were going into a completely different direction. First, you have already heard there was this lack of sharing understanding about what furthering equity really means. At the beginning, there were months of discussion about the operationalization of equity. That was the mantra for a while. Then these kind of discussions then translated into or materialized or made patent a lack of sense of urgency, because there was such a different understanding in the room about the fundamentals, the basis, the foundation of a pandemic agreement to be, that really this could not be conducive for a sense of urgency to conclude something, because of these very diverse understanding. Then from that diverse expectations and understanding of the fundamentals of the foundation, then we moved into when the exchanges began, then what became very patent was the lack of trust among the parties. In fact, if you hear, had you been hearing the discussion many times, many delegations were always introducing their intervention with, we are doing it in good faith, implying that, yes, there could have been something else floating in the air of the room. And then this lack of trust among parties, between the parties and the Bureau, between the parties and the Secretariat, between the Bureau and the Secretariat, then this is how they all, and this was a huge obstacle, because this really was hampering any sort of fluid, open, candid dialogue among everybody in the room. And as Fafa already mentioned, there was this issue of a lack of knowledge of and understanding of basic technical issues to start with. And I don't know how many times all the health attaché or the negotiators from the ministries of foreign affairs had to be primed and prompted and induced to the world of genetic sequencing and all animal-human interface and all this kind of thing that should have constituted the basis of any negotiation. They shouldn't have been subject to any discussion or explanation, because this should have been the ABC to move forward. But there was a lot of time that was devoted to that. And then another issue that what has always been challenging and is still challenging and is posing a lot of obstacles or roadblocks is the understanding of the legal status of a possible WHO pandemic agreement vis-a-vis the WHO constitution. Second, how such a WHO pandemic agreement would be framed in the context of the international body of law as a whole, and in particular how the WHO pandemic agreement relates to the provisions of the international health regulations, amended, non-amended. But the mechanics of the interactions between these legal instruments, internal legal, continues to pose challenges. And then in this context of different forms of lack of understanding, then this resulted in delegations getting very much entrenched into their own position. Sometimes it could have been a strategic posture, being very firm in the position. Some other time could have been just because of the lack of understanding. And that has been basically, I would say, until the last meeting, which was last week, a sort of dialogue established. And really there was, we could see the efforts by all delegations to try to understand each other, talking to each other, discussing possible solutions to craft a text that would be acceptable. And for the first time, I would say there was not a reiteration, explicit reiteration and statement of the red lines, because up until last week, many interventions were, this is our red line. No VMAT, yes VMAT, no PABs, yes traceability, you name it. And it was all about red lines. Last week, there was a glimpse of hope, maybe because I think one of the major, what could have pushed to overcome all these obstacles that have been faced during the last 3 years was the fact that many delegations felt that the importance of the multilateral context had to be reaffirmed, and with that spirit to say we have to get it done, we have to really be flexible and try to do it for to be better prepared to respond and prepare for pandemic, but also to sort of quote unquote save the multilateral context. And this is a bit what's happened, the breaking news from last week. Thank you. Over.
Thank you so much. I actually want to stay with you. I want you to reflect on how you see sort of states' commitments different, because there were amendments that took place to the international health regulations. So in your assessment, how has collaboration and cooperation happened in amending the international health regulations in ways that you haven't seen, or we haven't seen, not just you, with respect to the pandemic accord?
Yes. Okay. Then the process to amend the international health regulations was born as a reaction to the initiative of negotiating the pandemic treaty. I'm not going to name names. And in that context, we ended up, or the world ended up, with two parallel processes, intergovernmental processes led by member states, working on international legal health-related instruments. And the two processes were really, one was born as a reaction, and then they got intertwined inextricably. And three, at a certain point before the assembly last year, the IHR amended process became an hostage of the pandemic agreement process. But there was this fundamental difference in the two processes, which was same actors, same people in the room, but completely different mood, completely different attitude. And I think that most of it was attributable to the Bureau and to the leadership of the WGIHR Bureau, and to also to the fact that the expectations were really less for the IHR. There was less attention, less focus, less waves, and the amendment to the IHR were discussing a sort of protected environment in a bubble because nobody fundamentally gave a shit. That's the bottom line. And at a certain point, right before the assembly, progress were made, the discussions were fluid, but right before the assembly, because of the entanglement with the pandemic agreement, the negotiations for the amendment came to a halt. And in fact, we thought that nothing was going to happen at the assembly, but there was this sort of will by all member states to come together again, and basically they were locked in a room for 4 days and 3 nights, endlessly negotiating, and they agreed, they compromised, and I don't know if they eventually agreed out of exhaustion because the assembly was going to close. but there was a real, and the amendments that they were made to the IHR, they were all in theory justified on the basis of furthering equity. Further equity by at least alluding to access to product, at least alluding to access to financial resources. And I mean, it's not what some delegation would have wished to see, but at least in drafting, we had in mind the agreement, and we tried to be coherent and not too ambitious, but at least to set the foundation. I think that the amendment, in terms of furthering equity, they were aiming more than anything else to set the foundation of for a further amendment or for the agreement. That's but the atmosphere, they were same people, but same negotiators, but two different words. Thank you. Over.
Thank you so much for that. And I want to say, in the spirit of continuing to put some respect on our panelists' names, I should note that we have two members of the International Health Regulations Review Committee sitting with us, Professor Habibi and Professor Wenham. And one of the things that seems clear with the experience of the COVID-19 pandemic is that we need to do more, right? That all states showed a lack of capacity to adequately respond. All states experienced a big shock to their health systems and health infrastructure. And we would think that coming out, one of the lessons that we would learn from that experience is that, again, that we need to do more in terms of coordinating, collaborating within global health. And Professor Habibi, I'm turning to you. In your role on the committee to amend the international health regulations, what is your assessment of whether the amendments have led us to a moment of transformation in global health in terms of equity and other things that have been surfaced? Or do the amendments sort of continue to perpetuate the status quo that I mentioned in sort of my introductory remarks?
Thanks, Professor Sirleaf. Yeah, so I think I'll follow along really nicely with Roberta's comments as well. I think global health law, what we need to understand is that it tends to evolve, and not too much of international law. Some of you who've taken courses in international law may have read the paper by Hilary Charlesworth around international law as a discipline of crisis. It is a field that evolves in the wake of crisis often, and doesn't always evolve as much as we would like it to. But somehow when crisis occurs, I mean, the United Nations being born is the biggest example of this, right? Somehow when crisis occurs, new structures, new norms start to emerge as well. Global health law is no exception to that. Global health law evolves in the wake of crisis as well. The IHR, the International Health Regulations, experienced a wholesale revision in the wake of SARS in 2005. The current IHR has also gone through, I think, pretty significant revisions. We've looked at over 300 proposed amendments to the IHR in the review committee in the span of 3 months. And we could see very clearly that what states were telling us, at least from a large swath of the global south, was that we need to think about changing the DNA of the IHR. We need to think about making this an instrument about equity, whereas before it was always considered to be an instrument, a technical instrument. So the IHR was always considered as like having operational, technical norms around borders and vaccine passports, but not in the way we know it because of COVID, but generally on other issues like yellow fever. But it was an instrument that really had this really narrow idea. And in the wake of COVID, it became clear it could no longer stick to that status quo. So I agree with Roberta that what has ended up happening with the IHR is there are several good things it tries to do on the equity front. It tries, for instance, to get states to think about establishing a coordinating financing mechanism for when a global health issue arises. It is trying to get us to think more about WHO's role in the equitable access to medical countermeasures space. The challenge there, of course, is with WHO, it runs up against the jurisdiction and the territory of other international organizations, including WTO, WIPO, and so on. So there's always a bit of a tension between these as well as, of course, the conventional biological diversity. So there's always this tension with WHO and the space it can carve out for it of itself. I think I'm going to end on, I think the IHR has gone far and it's set a new ceiling beyond which it cannot fall. So now whatever the next crisis is, it will get us, and I'm sure there will be one, I'm sorry, but there will be another rethinking of the instrument, and there will be further amendments, and there will be building on this stuff. So it's not a lost cause. I guess I'll end with just saying that WHO's constitution was the first international treaty that enshrined the right to health in it. And so states have in the years since have lost that vision of the WHO as a transformative sort of place for giving all people the right to the highest attainable standard of health and wellness. Watching the words right now, but the core of it is that WHO had this expansive mandate, and it can still have that. It's just that states need to have the imagination to seize upon it. And there's no reason why the IHR couldn't have had, I think, personally, maybe lots would disagree, all the things that are happening in the pandemic treaty, we could have thought about the IHR and tried to integrate that to some extent within the IHR and not have this duplication and complication of legal mechanisms that is now the case. So not tinkering at the margins, but certainly, I think an improvement on what was there before.
Okay. Dr. Rahman, I'm coming to you now. I want to think about like how we can think about that. I mean, you do work in this space. And so how has what's happened in terms of our lack of preparedness, I won't say preparedness, our lack of preparedness, looking forward, how do we reconcile our lack of preparedness with an incapacity with sort of developing capacity, particularly in the global south? Yeah.
So one of the pieces of advice at the end of my contract to advise African group negotiators in August, September last year, I told them if PABS is not in it, don't sign the pandemic treaty. Just walk away. And a lot of countries were already thinking in that manner. I think legal preparedness from now on has to take into the context of what's happening in the United States quite seriously. And eventually, all these governments in the global north that are going right and embracing anti-intellectualism and all of this, is that there's going to be a brain drain from the global north. And there is going to be increased levels of disease in the global north for multiple reasons, right? Aside from firing of epidemiologists and all of that kind of thing, but also climate change, and we're seeing malaria in Southern Europe and all of that. So there's going to be more disease in the global north, and we need to think about that from a global south perspective of what that means. I think it's a good start that Indonesia and Malaysia already have domestic ABS laws, and I think Africa needs to go in that direction as well. But I also think that there's a lot of indigenous expertise within Africa that needs to be emulated elsewhere. So there are good examples such as Rwanda and the way they handle Marburg that can be mobilized and leveraged upon in terms of South-South learning. So for me, there needs to be a lot more domestic and regional stuff going on. But also in general, I think there needs to be a cohesive strategy. And we do have an article coming out in the Diplomat about this, so stay tuned. But a cohesive long-term South-South strategy, not just on health, but also on climate, on security, military strength, on culture, and what this means in the next 20, 30 years for the South.
Thank you. So I want to just encourage you all remotely to put some more questions in the chat. I see some will be moving to our Q&A very shortly after hearing from Professor Wenham. I wanted you to talk about the role of gender in global health and like what transformation in that space might look like. Yeah.
Thanks. I mean, I think it's a really interesting question, particularly after, hearing so much in the treaty about equity, right? And equity almost becomes synonymous with vaccine equity. And I think we're losing, and maybe it's through, obviously everything that's transpired in the last 5 years, but we're losing that other dimensions and other intersections of equity, which are kind of just being forgotten about. And, we can see in the treaty, right? We can see that gender's been watered down, right? It kind of got introduced and then it's been watered down, and the current draft has gender only being mentioned, or women gender only being mentioned in terms of workforce and in terms of elite representation, right? Maybe that's because it's the low-hanging fruit, right? It's the ones that actually can get agreement, and we know there's significant tensions across the multilateral space about language of gender. So it's the kind of opportunities where you can get progress, but that's doing a massive disservice to, decades of feminist challenges around, equity. And I think it's a real misstep in this context. Again, we see it in the IHR. There's not, the gender only refers to women as travelers and being protected, or gender not being a characteristic that can be used to penalize people traveling, but also through elite representation in committees. And we've done a lot of work on gender for years on this, and we spoke to the feminist foreign policy states who actively have a feminist foreign policy as part of their all their international affairs, and said, why aren't you pushing this in the treaty? And the answer we got was, it's not the most important thing, right? We're willing to trade it because what we want is prevention, One Health, or perhaps an access to vaccines. And so it's just going to be a trade-off. And, again, this is a challenge. You talk about lack of coherence with, and Roberta was talking about lack of coherence with the IHR, what about lack of coherence with CEDAW? What about with established legal mechanisms that we have that are kind of not being included and not being in the text? And I think it's also constitutive of the fact that, there hasn't been a big CSO engagement in this process, right? The actors who might traditionally be pushing for other forms of equity haven't really been given a participatory role. So we're kind of not seeing these pushes for other forms of equity. And, this is not a unique case, right? I think we have to understand this in the broader landscape of gender backsliding across domestic and international law, right? I mean, it's alarming, but it's not unique. But, where progress can happen, we've just lived through the biggest pandemic of our lifetimes. So, the argument we used to get before COVID about why governments weren't considering gender in their pandemic policies was, oh, there's no evidence for it. Well, now there's a whole heap of evidence, right? I can tell you 10 different ways why gender matters in pandemics, and I can give you the evidence, and I can give you the evidence from any country around the world, and it's still not getting considered. And I think we need to have a big conversation about this as well.
Thank you. So we are now moving into questions, and I want to shout out my global public health students for helping to shape this round, because they have given us really thought-provoking questions that a lot of the panelists, we're running away from. So we are going to get into that now. Again, encouraging those of you online to go ahead and put some questions. But the first one, I want to come to you, Dr. Rahman, to think about global medicines, especially given Professor Wyndham's comments around access to essential medicine. And so what are the legal and policy solutions that need to be put in place to help spur transformation in that space?
So on access to medicines and diagnostics, I always say access to medicines and diagnostics because I have a colleague at the University of Winnipeg who did these calculations, and actually the deaths resulting as a result of one lab worker migrating is actually higher than one doctor migrating, because people just don't get tested, right? So is that we need to think about in that cohesive South-South strategy, that one of the elements that we've proposed is a revamp around the whole medicines and diagnostics development structure, and that has everything to do with multiple things, right? There's the intellectual property system, which needs to be reformed. And that's not necessarily going to happen at the WTO. I have a co-author who said, no, we need to reform WTO. And I was just like, I just don't think it's going to happen. And I think that putting it in the paper does a disservice to what we can actually do. But we need to utilize the TRIPS flexibilities that we've given. We need to increase R&D funding to Global South scientists, and Global South governments need to do that to increase the funding for Global South scientists, and that needs to be done within their own borders. There is going to be a lot of expertise lost from US institutions that Global South countries can leverage upon. People are looking for jobs, use it. And from a legal standpoint, I mentioned the ABS laws, but there's also all sorts of biosafety, biosecurity laws, and in general laws around a lot of thinking around all these bilateral agreements that are happening between the EU and African countries to poach the data and not have that link to benefits. But there is a dearth of capacity that I really need to talk about, because in all my work advising the Africa Group negotiators, I met a lot of lawyers who were kind of generic lawyers who had kind of fallen into health, but they weren't specialist global health lawyers like myself. And I really think that capacity needs to be filled in. It's really different to have a lawyer who's just fallen into global health as opposed to a lawyer who's genuinely studied it and can attest to that through their academic standing and learning. So it's not just about the laws and regulations that we need to create, although we do need domestic ABS laws and biosafety laws and that are locally relevant. But we also need the capacity to bring it there, and that does mean specialist global health lawyers.
Thank you. So Dr. Andregotti, coming to you. There are so many changes in the global health funding landscape, and I wanted to ask you to just reflect on what you see as some of the positive and negative effects of these changes.
Is it to me? Sorry.
Over to you.
Okay. I was hoping it was for someone else. Okay. Yeah. No. Okay. The change of landscape. First, even before the funding aspect, as WHO, we have been. What we are going through now is the withdrawal of the US from the World Health Organization. This was communicated to the UN Secretary General on the 22nd of January, and the withdrawal of the US will be effective on the 22nd of January 2026. Now, this means for the organization itself that the main contributors in financial contributors in terms of assessed contribution and voluntary contributions is not going to be there any longer. And technically, as an organization, we are going through this perceived or real existential threat. This is our status and feeling as of today. This has an impact within the organization, of course, on staff, personal lives, but most importantly, as an organization, we are very, very much concerned on the negative public health impact that such a freeze of funding is having in different settings and on different populations across the globe. This is our main concern because we are in this situation of having, as public health agency, we have to anticipate the negative impact, and we have to figure out a mitigating intervention of the negative consequences. And this is, I think, is going to be a major strategic shift that could be seen as positive, but to deal with devastating public health consequences. And since ourselves are being shrinked, then we have to face a rethinking and reshaping of our structure first, and second, of our modus operandi for delivering for serving member states. And of course, the withdrawal from the US, together with the financial aspect also, and together with the public health consequences, also could have an impact if we look at it from the IHR perspective, because we have always referred to the IHR as something keeping together a chain of links, where the entire world has a stronger, the weakest link, and now we are in the situation of missing a link altogether. And this, of course, when it comes to the sharing of information on acute health event with potential international implications, the impact is huge, because it could lead. It could mean delayed alert. It could mean delayed response for both the state party who is no longer to be there and the other state parties. Then basically impact across the board. Now, we are, as an organization, all the senior management is pulling all the stops for to invite the US to reconsider their position, but at the same time, I think we have to find the energy and the strength internally to take the opportunity as a positive, in a positive sense, and try to introduce those radical changes that have been invoked by many for the reform of the UN system as a whole. And WHO now is could be the sort of guinea pig, and I think we should have the energy, the courage, the strength of operating in a way that only rely on predictable resources, because we have seen how relying on something voluntary or means. Then this, yes, situation extremely complex, never faced it before, but I think there is always a silver lining that we will have to seize somehow. I hope we will have that energy and strength. Over to you.
Thank you so much for that. So we're gonna go a little bit over time just because we want to give everybody a final word. I know that some of you may have to go to class, some of the students, but for those of you who are able to stay, we hope that you will stay and indulge us a little bit. We had some technical difficulties eating into our time on the front end, so we're hoping to take up a little bit more time on the back end. So given that, I wanted to invite you, Professor Wenham, to think about what other mechanisms do other countries have to respond to these changes that we're seeing?
Yeah, so I mean, as Roberta's been talking about, you know, the US withdrawal from, you know, not just WHO, but the global health space in general has massive ramifications for everyone else. And it's not the first time it happened, right? I mean, in the first Trump administration, we saw the withdrawal. And we saw other member states trying to fill some of those gaps, particularly Germany, Scandinavian states trying to plug some of the gaps, particularly trying to plug some of the gaps around sexual reproductive health. And that isn't going to happen now, right? I mean, I don't know if any of you follow German politics. There was an election last week. You know, they've got their own issues to deal with at home, you know, massive far-right movement encroaching now the main opposition party. They aren't going to be funding multilateral organizations in the same way they might have been previously. Similar challenges in Denmark, for example. So we've got this challenge, right? And yes, the US has left, but I would also ask, and Argentina, where are the other 192 member states, right? What are they doing? And if you want to look at, you know, following the money, right? Because that gives you a good indication of actually what governments think. And you have to ask the question of, like, is funding a strong WHO actually what governments want? And if you look at the WHO last year launched an investment round for the first time, right? So it's moved from trying to garner money in different ways, trying to model the success of the Global Fund and Gavi's investment round fundraising. And they haven't got much money, right? They've asked for 7.1 billion. So far, they've got 1.6. But if you look at particularly those middle income states, those states that are calling for transformation, those states that are trying to hold the global north to account and saying, you know, we don't want it to be dominated by the US. We don't want to be dominated by high income governments and, you know, global north. Well, what are they doing, right? And I think the alarming thing is not that much. I had a quick check this morning, you know, Brazil has contributed nothing. China has only contributed 20 million. South Africa, 1 million. India, nothing. Put that into context, Luxembourg has contributed 52 million, right? So that's more than China, right? The Gates Foundation, only 40 million, right? Like, there are a couple of states which are disproportionately giving money, and then there's a lot of gap. And I think we need to talk about that as well, right? Because this should be the opportunity for other governments to step up. And if they want to see transformative global health, this is the opportunity, right? There is this leadership vacuum. It can be filled. And, you know, I think that's a question we should all be asking. Just also wanted to touch on one other thing, because it was one of the questions that came around from your students, which is linked to this, which is, you know, USAID crumbling, right? Being merged with the State Department. This happened to us in the UK 5 years ago, right? We had a merger of the Foreign Office and the Department of International Development. And we also had a reduction in we used to have a legal precedent where in the UK we had to spend 0.7% of our GDP on overseas development assistance, which also got vetoed by our previous administration, right? So we've had a reduction in spending and a merger of strategic Foreign Office with Department of International Development. And the lesson learned is it doesn't go well for anyone, right? And I think this is the thing that we need to bear in mind. Yes, the scale is smaller. UK development assistance was never the same size as USAID. But who that affects the most, I think we also need to focus into account. So the UK Parliament did some analysis of the impact of the cut of overseas development spend, but also the merger of FCDO and DFID. And basically, there was huge, the disproportional impact fell directly on the most vulnerable women in the most precarious countries, right? So we saw, for example, 500,000 women in Yemen are not going to be receiving healthcare as a consequence of UK cuts. There's going to be a significant reduction in unsafe abortions averted because the UK government was high on pushing sexual and reproductive health rights. On maternal mortality went up, particularly in places like Syria and Yemen. And so we're seeing these real life impacts on those most vulnerable. And this analysis also demonstrated that UK lost soft power, right? It's not just about the direct impacts on the short term. You know, UK's position as a consequence of reducing its role overseas has a significant impact domestically, right? We've had a decreased impact of aid, decreased influence in multilateral fora, decreased role in international affairs more generally. And I don't think that can be underestimated. You know, I think it's a big question of the impact of this both in the short and long
term. Thanks for that. I mean, I think what we can take away from that is the budgets are a statement of our values. And so by looking at what we commit in terms of financial resources, and doing actually a comparative analysis, right? Not just what resources are dedicated to health, but how is health funded or defunded in relation to other priorities, and what are the countries' stated priorities with respect to their values, and how do the resources they dedicate to those values reflect that. And I think one of the things that is clear from the Declaration of Alma-Ata in 1970s, the call from the global south was that health for all is possible. Like, what we have is a severe misallocation of resources. We have a prioritization of militarization and war, and that even in 1970, right, there was a call to reallocate the resources that are dedicated towards militarism and towards defense industries and endless wars, towards achieving a more healthier world for all, right? And that call is still rebounding until today, right? Until that call might have been made yesterday or today, this morning, right? And it's still a reflection. Sorry, I had to jump in there with my moderator's directive, but let me turn now to the question from the chat. I think we can only take one. Some of them we've already covered. We'll turn to the one directed at Professor Habibi, which is, you can see it in the chat, but basically it's just like, how do we make sense of states sort of glomming onto new concepts that don't have as much sort of existing sort of legislative, I guess, context, terms, and use those terms as opposed to sort of things that are more conceptualized and maybe have more architecture to support them. And the example here is the turn to equity as opposed to human rights. Yeah.
Yeah, sure. And I think, so this question also says one element of it, which I think I wanted to dismiss from the get-go, is the question asked, is it also about undermining human rights? Is it that we are trying to undermine human rights by inserting language such as equity and solidarity within the pandemic treaty? And I don't think it is. I mean, I would like to think that we're not that far gone from, like, we're not recoiling that much from the human rights space. I think it's partly an issue of comfort with some words within the public health space versus in international and other spaces within international law, but also sort of this notion that maybe human rights it's too complex. Maybe what we need to get at is just this equitable countermeasures thing. And for instance, not deal with LGBTQI rights and so on, that all the other, what they would probably consider baggage coming into the treaty text. I think that we can still work with that. There's still within the pandemic treaty and guiding principles that it will be guided by human rights, international human rights, and the right to health in particular. We have to read into these as lawyers. I think many of us have kind of a knack for interpretive kind of imagination. We have to read into these to say, okay, we're going to bring in the international human rights regime still, because you did insert within your preamble, right, this acknowledgement of all these international norms that already exist. You did include it within your guiding principles, and so we can still bring that to bear. And then civil society really has to mobilize around these terms within the pandemic treaty space. I think one of the challenges with the pandemic treaty is that, and Claire, I think Dr. Wenham, Professor Wenham alluded to this, it's about the civil society that has been coming to the table has been health civil society, largely. So there's folks who work in Medicus Mundi, some do really great work, others do very kind of key issue work, like dental issues or osteoporosis. Like they have very specific issues that they champion. We haven't brought as much the human rights civil society into these spaces. And so they need to kind of take this treaty, look at that language, and really interpret it expansively for the rest of us, so that it's partly a collective action problem now. If the treaty hopefully gets passed, we have to use those tools available to us.
So thank you. I'm gonna bring the session to a close with inviting our panelists to, and I'm gonna give you some time because it's hard. I want you to think about one word, or phrase, but it's a word, not a sentence, not a paragraph. One word or phrase, and it's a two-word phrase that is giving you the biggest source of hope and optimism in terms of realizing transformation in global health. I'm gonna give you some time, I'm gonna do some announcements, and I'm gonna come back to you. And we'll look at Claire's face. And so first I want to thank the Maryland Journal of International Law for helping to host this conversation. We have a number of co-sponsors, the Center for Global Engagement at the University of Maryland, Baltimore, the Law and Healthcare Program at the University of Maryland School of Law. Oh my goodness, the like administrative team extraordinaire, Lauren, Rebecca, Jehan, Natalie. Oh my goodness, we really wouldn't have been able to do this without you. You literally are the real MVPs. Thank you so much. I also wanted to say that please stay tuned to this conversation. It will continue. We'll be following up this conversation in an online symposium on global health at the Crossroads in the American Journal of International Law, where our panelists, alongside other brilliant minds in the field, are going to build on the conversations that we've had today to try to examine the persistent challenges in the multilateral system and think about transformation in the field. So I'll begin, because I know I did an unfair task, of the thing that is giving me hope and of realizing a healthier world and realizing transformation in global health, and that is social movement. Silence. You want someone else to go first? We can do a popcorn, okay?
I guess I would say young minds. The thing that is giving me hope is young minds.
I think innovation from the global south. I've seen some of that. Innovation. Innovation.
Self-innovation.
Self-innovation.
Self-innovation, there you go, there you go. It is hard, okay. Roberta, we're waiting at any moment.
Yeah, learning, capacity of learning.
Compromise.
All right. Thank you so much. With those words, we'll come to a close. It's been such a pleasure. Take care.